morning. Welcome to the Steps Forward Innovation Academy. My name is Laura Fritchie. I'm a project administrator on the digital health team here at the AMA. Today, I'm sure many of you are finding yourselves using digital modalities to provide care, whether through telehealth or other digital tools. So today, we'll be hearing on digital empathy, navigating asynchronous communication. If you'd like to learn more about the STEPS program, I welcome you to scan the QR code here. The STEP program offers a variety of playbooks, toolkits, videos, podcasts, tools, templates, and other resources that work to provide physician-developed strategies addressing common challenges in medicine and ways to transform practice. Here's a quick disclaimer. If you're new to using On24, here's a quick little layout of what you're seeing on your console. You'll see a little bit about the speaker. You'll see the presentational slides, and this will follow along as the speaker is going through the presentation. There'll be related content. These are other resources or links that are provided for you. There'll be a survey that you can take anytime throughout the session. You're also welcome to take it towards the end. You'll see the speaker feed, more information about the Steps Forward program and other sessions coming up in the future. And then throughout the presentation, if you have any questions, we welcome you to put them into the Q&A box. That's the Ask Question widget that you'll see down in the left-hand corner. And with that, I will be introducing our speaker. I'm excited to introduce Dr. Matthew Sakimoto. He's a virtualist primary care physician in San Francisco. He's also a fellowship trained in clinical informatics at UCSF with a focus on virtual care and clinician efficiency tools for the EHR. Through personal experience at multiple health systems and telehealth startups, he's developed an approach to digital empathy and website manner to better connect with patients. Dr. Sakimoto, I'll pass it to you.
Thank you so much. Fun to be back. Good to see everybody again, and we'll jump into it. So today, learning objectives, really, I got into this idea of digital empathy as I started to do a lot of telehealth work, and then particularly as we move into text-based scenarios and communicating with patients. Looking at strategies for enhancing that empathy in written communication, and then I think we've all experienced the challenges, but also the opportunities for this asynchronous text-based care. So we'll talk through kind of what I've done and experience, but also would love to learn from the audience as we go along as well. 4 steps, and I really like the setup that the AMA has put together for really breaking things down. So it comes down to 4 principles for me: really acknowledging the receipt of the message, personalizing the communication, setting clear and consistent expectations, and then really recapturing the patient voice. There's a lot of information that comes in from the patient, but I think we can also incorporate that into our workflow and into the note. We'll start kind of with a case study of sorts, so purely fictional case, but I think we can all resonate with this. Imagine Mrs. Johnson, a 68-year-old, heart failure, frequently messaging in with her doctor, concerns about different symptoms, long, sometimes span multiple messages, sent at odd hours. Initially, her physician found these messages overwhelming, really felt like they needed to respond effectively. Sometimes it can take a couple of days because we're all in clinic and there's a lag in the kind of generic message templates that really don't fully capture Ms. Johnson's concerns. Sometimes a staff member will message on behalf of the doctor, but there's some conflicting information between what the physician says and what the staff and the admin are messaging to her. So as a result, increased anxiety, more messages, kind of increasing in urgency in those messages. So overall, I'm sure we can all relate that this inbox messaging, because we don't have that face-to-face feedback, can lead to some friction both between the patient and the care team. Looking through here, I kind of think of virtual care as this continuum. So people talk about telehealth. I've really started to expand that to mean this whole spectrum here. On the far left, there's texting with patients. There's kind of the store and forward, send in a picture, telederm setup, and then the chat and the chat bot are these kind of asynchronous, semi-synchronous modalities that you'll see here, and we'll really focus on that chat portion. Traditional telehealth, I think, kind of falls under that telephone call, video visit, moving a little bit into remote physiologic monitoring here. And then even on the far end of the scale, you can have everything from telepresenters, so very acute situations, so a tele-ICU or telestroke program, or even group visits. So these kind of synchronous modalities are new and new ways to use it. But today we'll really be focusing on that chatbot section. And I personally like using messaging with patients. If you kind of look here, how can we shift task-based things like the medication refill that was mentioned in the case study to just messaging and kind of just being taking care of things, not requiring that face-to-face. As you can see here, if you do a video visit for a medication refill, the setup, the time it takes anywhere from the 15 minutes of the visit itself on video, plus minus all of the getting ready and prepping the patient for that. So I kind of use this idea of this meeting could have been an email. Many times this video visit could have been a message. And as we start to move those into messaging, we can really impact more patients per day. The idea that I have here on the far left side is a productive physician. You can kind of see and write a note on maybe 30 patients a day. But think about your day or your clinic day. How many of those could have been handled by a message? I really like this setup here with primary care as this coordinating platform. So my current practice, we practice team-based care. So there's myself, physician's assistant, as well as a medical assistant. And between the three of us, we're really able to send messages back and forth, and everyone can practice at the top of their license. So our pod really impacts probably about 30, we can do up to 30 patient messages or patient lives an hour, depending on the things that they need at any given time. The other thing that I really want to stress, I guess that I bolded here, is the tasks don't have to fall on the shoulders of a single physician. Really, that team-based care, being able to route messages, adds so much flexibility to my day. Again, requires a little bit of extra communication within the team, but you can really unlock the care that you can provide for patients and the timeliness of care that you can provide for patients. So what is digital empathy? Again, thank you to the AMA for having me back. I did a talk on this about video visits, but a little bit of interaction here too. I guess in the chat, like how would you connect with someone that you'll never meet in person? This could be in a clinical context, but also just even in a social context. And I'll take a look at the Q&A here if people want to just put their answers in, and we'll go through. Taking a look at the chat as well, someone was asking, what is a virtualist? So for myself, I wish I'd coined the term. I think I took it from somebody else, but I practice primarily telemedicine, both in the video visit format as well as the messaging format. I also maintain a hybrid practice. So I have 1 day a week physically in clinic. I think it's important to see both patients and members of the care team. But the virtualist part is doing primary care in a primarily virtual format. Perfect. Let me see if I have anything in the main chat here. But yeah, if you're interested, definitely feel free to drop them in the chat, and we'll also have time for Q&A verbally as well. So what is digital empathy? It's traditional characteristics of being empathetic, showing concern and caring for others, but then expressing it through computer-mediated communication. So as we have different modalities to talk with patients and with each other, how do we help translate that into the digital format? Initially, so again, as a virtualist, there's an increased reliance that I have on patient-reported signs and symptoms. So we can't always get a blood pressure using our clinic blood pressure cuff. We have to make sure that we can trust the patient-reported vital signs and things like that. So communication, trust, building rapport, really crucial to that virtual therapeutic relationship. And a lot of times people are concerned that doing care over video or doing care over even just messaging is a little difficult, but for me, it's really unlocked the ability to do chronic care management. So I think of ideas about interstitial care. So it's kind of, we're used to a very episodic based thing where I see a patient to manage their diabetes today, follow up in 3 months, but there's not a lot that happens in the in-between. This interstitial care, it's kind of proactive, it's continuous. I have the bonsai tree here just with this idea that small little nudges kind of throughout and in between can have really big changes. So really creating more time through tech-enabled team-based care. So that extra time that we get really makes up for that lack of physical touch that is missing when you can't do an in-person visit. And Digital Empathy 1.0, this is actually perfect timing. I think someone was asking, is there a link to the Video Visit Empathy webinar? So this is a paper that I wrote with a patient advocate, Sarah Krug, back in 2021. And let's see, I can also share out the AMA video that we did as well. But this really pertained to video visits for the first time. A lot of people were doing visits with their doctor over Zoom or over other video platforms. So eye contact through maintaining eye contact through the web camera, making sure you have good lighting, framing on the screen for both the patient and the physician. These are all ways to create that connection in a video visit format. So here's the written version of what that is here, and then we will also try to find you the AMA webinar that we did as well. But moving on from video visit empathy, how do we embrace the inbox? Like I said, I actually personally like my inbox. So I guess questions for both actually clinicians and if we have any patients on the call, do you enjoy the option for these clinical conversations via secure messaging or in-basket messaging? And again, feel free to drop that in the chat or the or in the Q&A. Perfect, and I'll leave this up for a little bit there. I guess kind of answering for colleagues that I have, most people don't like their in-basket and kind of view it as an extra thing. For me, I'm also lucky in that like large parts of my day are actually dedicated to inbox management, and a smaller percentage is dedicated to face-to-face time. And I appreciate Martha's liking the ability to send the message. And again, we'll talk through the upsides and downsides of that. So inbox explosion, I think this is the downside of that. Really good piece by Dr. Michael Stillman about death by patient portal. It's a little hyperbolic in the title, but the content of the message was very much on point, where I'm not sure if patients realize like the volume of messages that come in clinically to physicians in basket or clinicians in basket these days. Definitely during COVID, that was the main kind of lifeline for keeping in touch and keeping care going in a post-COVID world. Again, I actually view it as a net positive, but I think our structure of our day hasn't quite come up to that, caught up to that. So this idea of the inbox explosion is definitely there. Even myself and definitely talking to colleagues, we're feeling it. But how do you balance that? So today, we'll talk about different steps to address digital empathy. I call it digital empathy 2.0. So connecting with patients through the written word, not just through video. So likewise, kind of did a follow-up paper to this. So worked with Dr. Aditi Joshi. So how do you do written word connection with patients? And the link is available here. Perfect. And I got some extra depending on when people like to use messaging, depending on the clinical conversation. If the patient's communicating follow-up vitals or symptoms, it's good. If the patient has a new concern or new complaint, usually it generates a visit. And we'll talk about different ways to route those and scenarios. So going back to the 4 steps, acknowledging the message, personalizing the communication, setting expectations. Actually, number 3 goes well to Scott Joy's comment there about when they should do a visit versus just continue messaging, and then recapturing the patient's voice. And thank you, Laura, for dropping the link to the video visit empathy presentation. So going into this is one, and I reference back to the fictional case with Miss Johnson. Acknowledging the receipt with a approximate ETA really makes a difference. I think a lot of times patients message in. What I noticed actually even with my team, we would be diligently working on it, calling a specialist or figuring out where the patient's lab result ended up at. We're doing a lot of work behind the scenes, but the patient doesn't realize it. So really just saying like, hey, we got your message. And then what you did with it. Sometimes my MA will say, forwarded it on to Dr. Sakamoto, and he will address it by the end of the day or by the end of the week. So setting those clear timelines, acknowledging receipt, even that has helped to really knock down the amount of kind of repeat messages that we'll get from patients. Because a lot of times they're anxious. They're not really sure what this new symptom is or what their new lab value showed and why that's concerning or not clinically concerning. Step 2, once you've acknowledged the receipt, is to make it personal. I actually used a lot, we're on Epic, I used a lot of dot phrases, so these are kind of like pre-populated phrases. Your labs look fine, things like that. But what I realized is particularly when you're trying to build that rapport with a patient, again, a lot of my patients, my first contact with them is through video, sometimes even just through messaging. Building that relationship, adding a personal touch actually does make a difference. So I've really cut down on my use of dot phrases for connecting with patients. I kind of think of it like the digital version of a handwritten thank you note. It's nice to get those every so often. And at least on that initial visit, particularly when I'm doing that rapport building, I try to make it as personalized as possible. And then this is the setting the clear, consistent expectations. I think one part of kind of during the COVID time was there were a lot of things that we handled via messaging that probably should be handled in person. So being able to redirect patients back and say like, hey, this is these are the norms for how quickly we can respond. You know, we're not getting back to you within seconds or even within hours. If your clinic has the capacity for it, like our clinic does, usually we tell patients that we can get back to you by end of day. So we try to maintain that connection with patients. Sometimes if your clinic is impacted and you don't have some of the mechanisms in place, setting those expectations like, hey, you know, your doctor or your team might get back to you in 3 to 5 days, kind of letting them know, again, acknowledge receipt and then give them that approximate ETA. The other thing is like what can and can't be handled via messaging. So I will say actually personally, like I'll handle some lower level, lower risk clinical concerns over messaging, particularly if it's a patient that I've known and these are things that they've had and they're able to reliably report their symptoms, so simple UTI cases, urinary tract infection cases, things like that. We actually will handle some clinical things, but again, clinical judgment, learning to do those things, pulling up and saying like, hey, I think we should like hop on a video call, or this seems really serious, you should come in person. So setting those expectations and making that clear from everything from you to the nurse practitioner to the MA, I think is important again for that consistency with patients. And finally, this is one that I didn't really realize. I kind of, I'll be honest, took the long patient messages as sort of as a negative initially, but it's really a way to capture the patient's voice through this idea of like narrative medicine. That helps me think about how do I treat this problem that the patient has versus what's the whole person context here. So having that, going back to the bonsai tree, having those multiple repeated interactions with the patient, you kind of get a sense of like, why are they so worried about this, you know, clinical symptom that doesn't seem that worrisome, at least to me. The other thing too is turning these text threads into patient stories. You sort of get to kind of see this evolution of what's happening to the patient's journey in real time. A lot of times before, they would present to the clinic much later in their course. You kind of get like third-hand report of, oh, I think my cough started 2 days ago. No, sorry, I forgot. No, it was actually 3 days ago because it was this party and it was over the weekend. Now, as you're getting it in real time, you actually have a timeline of what's going on. So at the point that I'm either seeing them for a video visit or just kind of managing it, things are timestamped. So the time course is actually much clearer. So I've really realized that like having, again, a lot of these messages seemed overwhelming at first. We've been able to kind of reprocess them in our clinic to really have that forest for the trees look and really have a much better overall patient story and patient narrative kind of going into a lot of these new concerns. So usually these do end up getting escalated to a video visit for things that I need to address, but I'm going into that video visit with a much deeper understanding of what's going on than if they had just booked an appointment 2 weeks out and then we're starting then. Perfect. So those are kind of the 4 steps that that we go through. Again, to reiterate, it's acknowledging receipt. Actually, let's see if I can pop that up for everybody real quick there. Again, just to recap, it's acknowledging the receipt, personalizing that communication, setting those expectations, and then it's embracing the patient narrative there. Perfect. And then just kind of some practical tips and tricks. I actually left a lot of time because I want to be able to allow for patient and physician questions as well. Few things here, and I've realized there are some differences both in personal life and otherwise with unique text-only communication challenges. So a simple question such as, can you review my labs? The way that a short response is received by a patient varies differently from patient to patient. It's definitely generational as well. So sometimes that short response can feel abrupt. Even punctuation, putting a period versus an exclamation point. Are you overshowing your emotion? Is it, is it overenthusiastic? Does it seem fake? These are all kind of things that actually run through the minds of patients as we've kind of talked through them. Emojis, really, really different. Again, generationally, sometimes that thumbs up emoji in Gen Z is viewed as hostile or passive aggressive. So even, again, emojis, short responses, these things have different meanings across different patients and different patient generations. And finally here, this idea of kind of the read receipts or the being left on read, or having the typing bubbles. That goes back to that point number 1 of acknowledging receipt. Patients sent in the message and they're wondering, did they see it? Did they see it and they're just ignoring me? So this idea that, and even some of the patient portals can actually will send read receipts to patients. So again, letting them know you got it, but also saying that like, hey, we've handed it off to somebody else. But these are differences where you don't have that synchronous closed loop communication. So the space for misinterpreting any of these responses is much larger now. Perfect. And how can you build in some of these patient expectations or just patient communication norms? I like this idea of speed bumps. Sometimes I think we do this as like in our daily life with email messages. So I'll do this a lot if I'm working later at night and about to send out an email. I'll choose to send it later, so you can have it send in the morning rather than send in the middle of the night. Similarly, you can kind of have these send later, either 1 day later or even 1 week later, to set those expectations with the patient. So I will say I admit to kind of delaying some of those responses. Even if I see a patient message come in at 8:30 a.m. today, it's quick, it's easy. Sometimes, depending on the patient message, I'll actually delay the response to the patient. I'm still taking care of the message, still taking care of the patient's clinical need. But if it's not time sensitive, kind of teaching the patients basically that like, hey, these messages can wait 24 hours or 72 hours. This has been really helpful. The 1 week later message has been really helpful for me. I'll be honest, mostly because I'm kind of forgetful. So if I see a patient today and we're talking about blood pressure, we do some change on the blood pressure med, I'll actually just post date a message to say like, hey, this is a post dated message. And then how's your blood pressure doing, 1 week later? Are you having any side effects? So it kind of allows me to address the patient's clinical concerns in the moment when I'm thinking about it today and not have to have like a reminder that I need to act on a week later. So these are kind of nice ways that the messaging has really helped my chronic care management for patients. Perfect. And a talk wouldn't be it wouldn't be a talk in 2024 without talking about some level of AI. So this has really changed my practice in interesting ways. So how has AI and empathy been used in medicine here? There are a couple of different programs where they'll actually draft messages for you. So again, kind of going back different ways about using ChatGPT or things like that to say like, when we're tired, it's 4:30, we've done a full clinic day and like there's 15 patient messages to get through. We're probably not our most empathetic selves. And the nice thing about computers is they don't get tired. So how can we kind of actually learn from the bots, so to speak, to one, kind of acknowledge patient concerns and then also do these things here. This is probably 1 click longer than I would do for a message, but it's a nice starting point. It's a way to kind of draft messages to, again, connect with patients in different ways. Perfect. Making sure there's no other questions. And actually, yeah. So, and again, I wanted to make sure I left lots of time for questions. I appreciate everyone that's been in the chat so far. But yeah, also happy to chat about video visit digital empathy, go deeper on the written word digital empathy, and welcome any feedback and or outreach via email. Thank you so much.
Well, you answered my question. I was thinking largely about AI and automation, and does that detract from, the patient experience and from empathy? But that's amazing to see that, you can kind of add your twist on it, but you can kind of still keep that centered when you're using those tools. So that's awesome.
Yeah, and actually to expand on the AI piece a little bit, I've seen this used in different ways. So this is an example from Doximity, but also, again, we're on Epic at our institution. And being able, it'll actually draft based on some of the patient's information. So it'll have access within our in-basket. It'll kind of know the patient's age. It can even pull in some of the patient's lab values. So a lot of the clicking and kind of extra clicking basically that I used to do, they're able to pull the AI embedded into the EHR is able to pull some of that information and provide extra context. And I'll be honest, like I said, some of the responses are a little off the wall, but some of that I was like, oh, I like the way that the AI phrased that. So there's definitely some imprinting and learning from the AI to my style as we've used it more.
I guess while folks, think through your questions, another question I have is any thoughts on how, leaders can better, foster training around this for providers at their organizations, or any resources or things you can think of that you would give to folks?
Yeah, I think it's hard. All this is so new, like the step function and the volume of messages that started coming in. Like we had already always had messaging, but it was a trickle, not a tidal wave. So I think everyone's kind of learning all at the same time. So I think that's actually the best way to do it, is to kind of form these learning collaboratives at your institution. Everyone's running basically a little mini experiment, I think, in each of their own clinics, and kind of learn best practices. Are some of your clinicians responding too quickly? Are some of them not responding at all and letting things really pile up? How do you, again, learn best practices from each other? I think is one at the clinician level. And then two, at the system level, there's a lot of focus on being how much stuff really has to go to the physician? A lot of times I'll see things where the initial message will go to the clinician, and then it's the clinician's job to triage. It's oh, this is an appointment request. That can definitely go to scheduling. I don't have to do this. So how do you not have the physician be the first point of contact for that triage? I think is also a really helpful way to take that burden off, and again, allow all the team members to really kind of practice to the top of their license. Some questions coming through the chat here. Martha, how do you train your team or other team members to learn about computer-mediated communication? Are there pre-packages? I haven't seen anything pre-packaged. I wish there was. I guess there's, again, the AMA has a very good series, and these team steps ones I think are quite helpful for that. I'll be honest, a lot of mine has been learning by doing and trial and error. Things that I used to do, like pre-populated dot phrases, I've kind of moved away from. So. And it changes. It really depends on your patient population. I do have a pretty diverse patient population. I see everybody from 18 years old to 98 years old. And some of my older patients are quite good at the messaging. So there's not an age breakdown, but there is sort of a willingness from the patient side to kind of engage in messaging-based care and kind of engage with the team. But no, I have not seen any pre-formulated things like this. So again, thank you to the AMA for having me and letting me at least share my experiences with it. Let's see. Scott Joy was asking, what are some of the best practices or techniques for training patients on how to use portals, digital tech like the Apple Watch, Cardi, et cetera? Yeah, the patient-generated data is a whole new world. Particularly with things like the Apple Watch and other wearables getting FDA approved for atrial fibrillation detection, things like that. So we haven't figured that out yet. I will say we are actively kind of looking for ways to respond to patient concerns when those come in. But no, we have not solved that one yet. Still working on that one. And I think that is sort of my digital empathy 3.0 is sort of what is the patient education side of this on how to manage when to send things in, when not to send things in. But yeah, the whole patient wearable piece is definitely something that we've been looking at and thinking about how to incorporate. The hardest part for the patient-generated wearables it's clinical-ish information, like an EKG tracing, but it's unsolicited. Usually if we send somebody out with a Zio patch or a Holter monitor, we're thinking about it and we're expecting a result back. Learning how to react and to incorporate that into the clinic flow for unsolicited, hey, my watch says I might have AFib alert. Yeah, we're still working on kind of what those workflows are. How soon do we need to respond what does that referral pattern look like, or next steps look like. So yeah, more to come. Maybe I'll be back in a couple of years to tell you what we've figured out. Let's see, follow-up question from Joel. I spend a lot of time messaging patients. Do you get reimbursed for time spent? Message response. Sorry, do you get reimbursed for time spent messaging? Are message responses billed to patients? Ooh, okay. I'll wade into this one. Let's see, I think I actually had a backup slide for this. So let's see if I can find it there. Ooh. There we go. So charging for certain messages in e-consults. This one was like a hot topic probably about a year ago now, where again, people recognize that this was coming up. And should you charge for messages? A lot of health systems kind of decided to do so. I'd say a lot of health systems put this into place. Very few messages actually get charged. So that's one piece there. For me personally, the way that my setup is I have a largely value-based care setup. So either patients that are on a HMO plan or Medicare Advantage or something where the goal isn't to generate RVUs or generate lots of patient visits. And that's one big shift that kind of, one, protects my time, but two, allows us to run some of these experiments. So if you're in a largely RVU generating setup, it's a lot harder to do this because that time is not reimbursed. For me, it's actually flipped. It's like actually when we can manage our patients' total cost of care, message them a bunch of times to avoid an ED visit, that actually is savings that we realize. So I also recognize that is a very different setup than most traditional primary care clinics. But going back to like our philosophy of charging for messages, so we generally don't. There's a few times that I have. But it's kind of it's flipping it, so it's a patient choice. It's kind of like, hey, I know you have your UTI symptoms, but we should probably discuss this a little further. You patient, you have the option of hopping on a video visit, or we can do an e-visit. But just so you know, like we're doing the equivalent amount of work, so you may get charged for it. So setting it up to being like, hey, we're just going to charge you, lands kind of poorly for the patient. Putting the context around like, hey, we're still doing a lot of clinical time thinking about this and using clinical expertise to make sure that you're safe and doing this in a proper way helps at least frame that charging for messages discussion. Perfect. Let's see, Kiara. Apps out there. There are apps out there that allow folks to get therapy sessions that are entirely chat and text-based. Do you think it's feasible for doctors' visits to be entirely text-based? So there's some for mental health. I've actually seen some that are also clinical care that is mostly, I don't know if it's entirely text-based, but like largely text-based. CirrusMD comes to mind for family medicine, as well as Summer Health for pediatrics. So that's a possibility. I think the most successful and, I'll be honest, safest one is when you have that care continuum that I showed there, kind of all within one office, or a really tight integration with a place that you can escalate to care. So I do a lot of it. I don't know if even I could do 100% messaging-based care. Having that ability to escalate to a video visit or escalate to an in-person visit with your trusted care team, I think is important. So I'm a big believer of the hybrid approach. Cool. Martha, how are you monitoring patients or getting a sense for what is happening with patients besides self-report? I guess there's self-report. The other half is there's spouse report. So I think actually, again, for a lot of my older patients, many of them with some cognitive and or dementia things, having their spouse and or adult child in the loop really helps with that piece as well. So I think we also, a lot of patient portals have proxy access. So again, I guess child that can access their parents, parent that can access their child's portal, and it's flipped. So for my older patients, a lot of times I'll kind of say like, hey, do you have someone that helps, that comes to visits with you that can help coordinate your care? And that really unlocks the ability to kind of loop in the family and keep them in the loop as well. So those are the main things. I'll be honest, I actually don't use a lot of physiologic monitoring. So there is, I guess, blood pressure is the main one that I'll sometimes kind of check in between with patients, but that's the main thing. Sometimes some weight management, but yeah, a lot of times, I mean, a patient will basically just send me a picture of their blood pressure logs for the past week or their glucose logs for the last week or so. So that's kind of the other way that we sort of do that interstitial care between the episodes of care management. Oh, and Martha was asking about what are dot phrases. Sorry, that's Epic lingo. Again, we live in a mostly Epic world, but these are sort of those like pre-populated phrases. I think macros is another term that people will use. So yeah, that's basically kind of entire sentences that with a single dot signature or dot refill, you can kind of start to pull in pre-populated phrases.
Well, I don't think if we don't have any more questions, I think we can end a little early. Thank you so much, Dr. Sakimoto, for joining us again for another session around digital empathy. This was great. As I mentioned with the resource widget, if you want to connect with us about the STEPS program or other sessions, toolkits that Dr. Sakimoto mentioned, you're welcome to go to the site and see more of those. I'll mention here quickly, if I can get the slide. We do have an upcoming Saving Time Practice Innovation Bootcamp in September. That's the next bootcamp event. And again, steps4.com is where you can go for more information. And thank you all. Have a great Tuesday.